All right. So hello, everyone. Welcome. Thanks for coming. Thanks for literally making it to this room because it's an adventure. Um, Welcome to Social Justice Through Scholarship, Integrating DEI and Research in Consultation-Liaison Psychiatry. My name is Abhishek Chandrakandai. I'm one of your presenters, and I'm very lucky to have with us Dr. Hermione Amono, Dr. Laura Suarez-Pardo, who's going to be presenting via recording, Dr. Kelly Irwin, and Dr. Ho Chang Lee. So in terms of disclosure, I'm not important enough to have anything to disclose. No relationships. Oh, thank you. Thank you. Appreciate it. So reminder of our learning objectives. Okay, awesome. Is this better? Cool. Awesome. So we're gonna talk about how to enhance diversity and inclusion within CL psychiatry research in both clinical populations studied as well as researchers. Appreciate how coalition building and community engagement can advance equity within CL psychiatry research, and critique current gaps in DEI-informed research within CL psychiatry, and formulate DEI-informed research projects at a variety of levels, from case reports to randomized control trials. So we're going to start with some audience participation. Yay, it's going to be exciting. Yes. Hello. So, yeah. So get your phones out. On the next two slides, you will see one term each. So if you go to menti.com, just get it ready in front, menti.com. Yeah. Okay. So what's going to happen, there's going to be a code that comes up on the screen. And then what you'll just be prompted to, so put in that code. Yes. And so what's going to happen is when you hear of a term DEI, just write the first three terms that come to your head. And then what will happen is as your terms pop up on the screen, the ones that get repeated get larger. And so then you actually see like a graphical representation of just our ideas of what DEI means. If you need, here we go. Hello, welcome all. We are just starting off a word cloud of what people think of when they hear the term DEI. We'll just give it a few seconds more. Awesome. So as you can see, just from asking a room full of CL psychiatrists what they think when they hear DEI, the first word that comes to mind is actually inclusion. Other big terms are equity, justice, and then you have like challenges, collaboration, essential. So a lot of thoughts around this, but it's interesting that the biggest word we think of is inclusion. Okay. So next, we're tell us the top three words you think of when you see the word research. I see you funding. Okay, we'll just give it a few seconds more. All right, thank you all. So if you look here, like a room full of CL psychiatrists, when they hear the term research, they're thinking, especially evidence. They're thinking knowledge, they're thinking funding, a lot of terms. So one thing you guys just to think about is when you compare this to DEI, like where do you see areas of overlap? Where do you see areas that maybe they differ from each other? Can we find some common ground between these two terms? So we're going to find a way to try to get this on the official slides later on for y'all to have for later. But going back to the presentation, we also wanted to give some official definitions of what DEI and research are. So DEI, a very, especially nowadays, politicized term, often misunderstood term, but what it stands for is an organizational framework that seeks to promote the fair treatment and full participation of all peoples based on 3 closely linked values. So the first is diversity, which is the many identities we carry, such as race, gender, sexual orientation, age, country of origin, religion, geography, and physical cognitive abilities. So that's diversity. Equity is the recognition that we have unique needs to be successful, that we must be identified in order to overcome uneven distributions and advantage. So as opposed to equality, this is what equity is. And then inclusion is how our identities are accepted in the circles we navigate, the extent to which we can be our authentic selves and fully participate in all aspects of our lives. And there's a concept that they brought up in the plenary just now, right? Like how much of yourself can you bring into the room, into your job, into this conference? Now, research, even more nebulous concept. So I just went off of the Oxford Dictionary, which said the systematic investigation into and study of materials and sources in order to establish facts and reach new conclusions. Federal regulations say that it's systematic investigation, including development, testing, and evaluation, designed to develop or contribute to generalizable knowledge. So what you're seeing here is this idea that this is systematic, it's discovery with the aim of creating new knowledge to move society forward as a whole. And there's many different types of research in CL, which are included, but not limited to qualitative studies, cross-sectional studies, cohort studies, randomized controlled trials, clinical reports, and electronic health record analysis, which Dr. Manu is going to be going into more depth later. So going back to that question I asked you to reflect on, like, what is the connection between DEI and CL research? Like, why is it even important? Like, why are you even making this workshop? And so it really comes down to the who, what, and the how. So the who, like, we have to make sure that our research community is diverse and inclusive. And we also have to make sure that the populations that we're engaging with research are diverse and inclusive, especially historically marginalized populations. And so particularly think about how, like, in terms of race, gender, socioeconomic status, geography, but also how, like, psychiatric illness and substance use disorders in and of themselves can make people, like, marginalized. The what, again, speaking of the impact of psychiatric comorbidity on health inequity, right, as we're just talking about right now, and also the impact of intersectional identities on psychiatric and general medical conditions. Like, it's tough having schizophrenia in America, but imagine how tough it is being homeless and having schizophrenia in America, being Black and homeless and having schizophrenia in America, being Black and female and homeless and having schizophrenia in America. We need to learn how exactly that's impacting the people we're trying to help. And then lastly, speaking of how, like, how do we do research itself in a way that ascribes to diversity, equity, inclusion in terms of, like, coalition building, being more in community engaged research. We talk about concepts like know about us, without us. So to this point, back in September 2020, the ACLP Board of Directors actually commissioned a presidential task force to recommend action steps to advance diversity, equity, and inclusion within our subspecialty society. And there was a whole section that really focused on research. So, direct quote, "We think it is critical to further develop CL psychiatry's scientific contributions to research and our scholarship regarding the role of systemic bias in health outcomes. Within ACLP, steps would include growing a diverse group of researchers in CL psychiatry and supporting the research focused on addressing health disparities, as well as fostering an inclusive and equitable research culture with a clear and visible commitment to promoting equity in healthcare. So, in interest of time, I'm not going to go over necessarily all of this, but this will be on the side. But these are specific things that the Presidential Task Force is recommending so we could actually advance this mission of DEI within CL research, including working on mentorship, which we've been doing a lot of work in, starting a SIG focus on addressing healthcare disparities, research symposia focused on DEI, and just even reviewing like publication reviews from a DEI lens. So, general workshop outline, so you know where we're going with this. So we did the word cloud exercise already. We defined DEI in research. I'm next going to invite up Dr. Ben Lee to talk about current gaps in DEI-informed research and pitfalls to avoid. Then we'll listen to a recording of Dr. Laura Suarez-Pardo, who couldn't join us in person because she's literally due any day now. So congrats and good luck in advance, Laura, if you're hearing this recording later. But we're going to listen to a recording to talk about barriers to minoritized researchers and research work in minoritized populations. Dr. Kelly Irwin's going to talk about coalition building and community engaged research and CL specific considerations. And then lastly, Dr. Mon is going to do an overview of research methods, and we're going to start a group exercise Q&A about like how to address DI questions within CL research. The very last slide at the end, we're going to challenge you all to think about, after going through this talk, what is one thing I want to do differently, like after leaving this conference, okay? So I'm pleased to welcome up Dr. Ben Lee to the stage.
Well, thank you for the introduction. I'm going to talk about current gaps in DEI-informed research in consultation-liaison psychiatry, and also talk about common pitfalls. And I don't have anything to disclose. And, I'm going to also, one of my positions that I have is as the chief editor of Journal of the Academy of Consultation-Liaison Psychiatry. Hopefully you're reading the journal. And I'll tell you what the gaps are from the perspective of the chief editor. And also, like, kind of think about, the part of my also career over the years has been someone who's been doing research in the disparity issue in Asian American mental health. So I'll tell you from that perspective as well. Early in my career, I devoted about 10% of my career, committed 10% of my career in Asian American disparity in mental health. And that's something I've been carried on, and I developed some perspectives. So I wanted to share that thought as well. And I'll talk about some common pitfalls in relation to being a DEI-informed researchers. Okay. So in terms of thinking about gaps, what's the first thing that you do these days whenever there is a question arises? ChatGPT. So I plugged in, and it gave us reasonable answers. I'm not going to go through, what they are. I mean, it's like limited representation, cultural competence, and, sexuality, etc., language barriers, and all these kind of things. These are all great answers, and you can read it in your reading, the printouts that you can have. But the reality is that in consultation liaison psychiatry, it's actually easier to identify what we have rather than talking about the gaps, because we have very little. Overall, our field suffers from having empirical research. Michael Sharp just did a presidential plenary talk. It's one of the very few randomized clinical trials in consultation liaison psychiatry. The last one was in 1992. So you can kind of think about how little research that we have in our field. So in other words, the little that we do, if you are focused on DEI, informed research or disparity research or equity research, we really have a rare opportunity, and we have to really do our best to make that count. And that's the pitfalls that I'm going to be talking about. If you look at the overall in the last 3-4 years since our journal started, when the journal moved from psychosomatics to Journal of the Academy of Consultation Liaison Psychiatry, until this year, there has been very little article that are related to DEI. There are some letter to editors that I'm just listed a few. And it's because there just aren't that many articles that are DEI informed. And then also when they are submitted, there's also problems related to the quality of the data that's being sent. So that's the part. We did last year for the first time publish the DEI focused issue in our journal, led by this wonderful editorial that Dr. Kandai wrote along with Dr. Mitra related to diversity, equity, and inclusion in consultation-liaison psychiatry and advancing the field through this editorial. And that there was also lead article that was really important. Quality QI study that's related to healthcare disparity in emergency interventions in the medical setting that was done by a team out of the NYU. And then it's followed by the Ask questionnaire, suicide screener, and its validity in Black youth. And then there was a commentary. But, to develop that kind of issue, it took a lot of effort. In other words, it just illustrates how little DEI informed or DEI focused research that we have. And this article that was highlighted in that issue does deserve some additional mention. It's a disparity research that actually tries to identify problems. It's about, are there some sort of a bias in relation to the psychiatric emergency in the inpatient setting when you are applying BERT, a behavioral emergency response team that many hospitals have? Very important topic. It's a quality improvement framework. I think every hospital should try this out. I'm certainly trying this out at University of Rochester because I want to know if there's any bias in relation to race and ethnicity, in relation to applying these, when you're calling for like security guards, do you have a bias? Very important topic. Well-conducted study. The results are not positive study. Despite really having a large sample size, when you start dissecting it out, it reduced the power to the degree that a conclusion cannot be drawn, which illustrates the difficulty in relation to this type of study. But it provides important framework for other institutes to follow. Very important study. And it's also important to kind of think about what kind of study are we interested. One is the health disparity study. Health disparity studies are the ones that talks about preventable differences in burden of the disease, injury, violence, opportunity to achieve optimal health. And that looks at, essentially, it identifies the problem, like the one that I just showed you. Are there a problem? And health equity study is the one that tries to develop a solution to the problem. Eventually, we have to move from disparity type of model in research in DEI by identifying the problems to equity type of studies that are related to providing solutions. And there's been call to actually move from disparity model research to the equity type of model in overall healthcare, because there are enough, a lot of people feel there are enough studies that are related to disparity. I've been part of that movement in relation to illustrating the racial differences, ethnic differences in terms of healthcare disparity. But our field, as in CR psychiatry, unfortunately, we haven't moved the budget yet. In other words, we still are at the stage we could use a lot of disparity type of research before we move on to the equity type of research. So that's one thing that I want to do. So to also give you a quick example of what it's like being a health disparity researcher. So early in my career, I'm speaking from my own experience. This is like when I was a fellow. This is almost like 15, 20 years ago. I noticed that, if you're Asian American, Korean American particularly, if you have a language barrier, you have a big problem in terms of getting mental health services or dementia care. So, at the time, I also noticed that a lot of poverty among Korean Americans, they don't speak English, and decided, I did my epidemiology training. Why don't I do this study? There's a bit of a quixotic idea. And so I got funding, about $250,000 at the time. It sounds like sizable, but in reality, it's a terrible idea to do that kind of study with that kind of thing. So idea is to develop this community representative sample and then develop some kind of examine the level of correlates diagnosis treatment for dementia and depression. And then also look to develop culturally appropriate psychiatric instruments in terms of instruments. So a lot of ideas. This is what you do when you're a young investigator, not knowing your limits. This is the sample. It's sort of like a population map of what I was trying to target. And essentially, there are big issues when you try to do this kind of thing. By definition, when you're trying to do research in minority, these are geographically distributed, isolated population, linguistically isolated, and it's really difficult to chase them. So you have to, instead of chasing the individual, you have to chase the community centers. So I utilize the churches. And then, because they don't speak English, you have to assemble a team that are bilingual. So you have to partner with a community organization is what I did. And then you have this questionable reliable measures. You have to find a way to validate those instruments along the way. So we did that kind of thing, and we tried to target a big study that sampled 26 churches. We interviewed 1,000 people, and did substantial amount of work. We brought a subsample of 200 people to the detailed interviews and etc. And eventually we did interview 1,116. But imagine like how much effort it took. We did identify problem, high rate of depression, very high rate of also suicidal thoughts among Korean American immigrant elders, and only very few, 8.6% of those people who report suicidal thoughts were getting any kind of intervention. And then those are the type of disparity type of research that you can do, identifying the problem that is. And then the prevalence we also quantified in terms of being able to find out what is the rate of MCI, mild cognitive impairment, as well as dementia. And we also illustrated how it's comparable. The only difference is that they're not getting any evaluations. They're not on cholinesterase inhibitors. And that kind of things are examples of how you do the disparity research. Eventually, though, these are all done around 2015 to 2018. We published these articles. It serves as a preliminary data for the next stage of equity study. So here's one equity study that Hera, Han, my longtime colleague, is doing. Now she's using this data to now identify people with undiagnosed dementia and develop interventions to help them transition into dementia care, so-called PLAN study funded by NIH R01, $2.5 million study. Another study done in Los Angeles by Yuri Zhang, again, an equity study related to how to provide support for the caregivers of dementia. And then suicide prevention study that's now being planned by Suyan Lee, my former mentee, who is trying to work with Korean church pastors to be able to teach them how to screen and intervene in case of people who are developing dementia. Again, trying to move away from disparity to equity, but you need to do disparity research first. And we don't have that at the moment. So what are the common pitfalls? It was really hard to do that kind of study. And that's conducting disparity research is very challenging because, I think I visited probably about 200 times into these local churches to do interviews and etc. during my career development, our K grant. This is when I was an assistant professor. But it is also very rewarding. Why do you do this kind of study? Because you have a sense of commitment and you have a sense of advocacy that you're trying to do. And by the way, funding is a problem, but it's improving rapidly. There are many DEI-focused studies that are now being funded. As you saw, these 3 studies that I illustrated are funded by NIH in a big budget study now. The bigger challenge is finding a mentor or collaborators for this type of study. So those who are conducting an interest, you really have to link up together. Third is that it's really difficult to do this type of study. You have to be really research savvy and better trained in relation to this type of study. And also, you have to balance your sense of advocacy along with the data that you're producing. I cannot tell you how painful it is for me to reject the articles that are DEI informed or DEI focused, because I know the heart of the investigator who's producing this. But I also believe uninformed data or mistaken interpretation or poor methods actually does disservice to the community, because public out there cannot take these kind of research seriously. So overall, what I wanted to just quickly tell you is that still there are very few research in our field in consultation liaison psychiatry, and we are very much looking for those articles. And we are still at the very beginning stage of DEI-informed study in a consultation liaison psychiatry. And there are many opportunities. And some people are starting to take that opportunity to illustrate these health disparity in our field as well. And we have to move from the disparity model to one day to equity model. And I talked about some of these pitfalls related to it. Primarily, it's difficult, yet at the same time, as I look back on those times, that's what I'm doing, is there's nothing more rewarding than DEI-informed and DEI-focused research. So thank you. And this is a shout out to my collaborators and mentor, Mi-Young Kim, who is actually based in Texas, who has mentored me over the years. And a little bit of a shout out to my group, Asian American Mental Health Journal Club at University of Rochester, and the Korean American Mental Health Suicide Prevention Research Group that I'm leading. So thank you.
I'm Laura Suarez, and I'm here to talk about psychocardiology research to explore and address healthcare disparities in minoritized communities. I have no disclosures. So I want to start by talking a little bit about some of the things that I've noticed as I build my personal trajectory and my research career, right? Hoping to become a PI and a mentor. A few things to keep in mind for this. I want to build a diverse and inclusive workforce while preventing tokenism. I want to be aware of barriers encountered by minoritized groups. And of course, I want to increase inclusion and diversity within participants. So if we think about international medical graduates, 25% of the US physician workforce are IMGs. And back in 2021, up to 53% of US-based postdocs were international medical graduates. So that's actually a pretty big group. If we think about those who are temporary visa holders, a lot of them are doctorate recipients, and actually that's on the rise, though females remain underrepresented. And there are enormous barriers about funding that we'll talk in a moment. The other thing that I've noticed is representation. So Black and Hispanics are underrepresented in the STEM workforce, particularly engineering. And that's problematic now if we think about, you know, all the innovation and technology that is going on in scientific research, including psychiatry. Women are underrepresenting and earning actually less than male counterparts. Funding is a major barrier, so IMGs who obtain faculty positions are ineligible for federal career development awards because of NIH citizenship requirements. So that academic advancement is going to be complicated. And then, recruitment. So as a personal experience in trying to recruit patients, particularly Spanish-speaking Latinx communities, lots of barriers and difficulties. So the IRB, policy requires official translation, despite some of the investigators being native speakers of the language of the study. The reviewers within the board are not diverse enough and not knowledgeable about the cultural sensitivities and underpinnings of this. These adds cost and time. There's actually very limited culturally sensitive resources and support, so that the investigators are really having a hard time making these projects move forward on a timely fashion. So if we look at this in more of a graphical representation, so IMGs, particularly those who are temporary visa holders on science and engineering, are on the rise. If we look at women, again, temporary visa holders, they're still underrepresented. And in the STEM workforce, Black and Hispanics remain underrepresented. And then, across all ethnic groups, women in STEM earn less. So we think about women, white women, Black women, and Hispanic women are at the bottom of that chart. So this study really looked at the distribution of race, ethnicity, and sex within the U.S. psychiatry physician workforce and the trends since 1987 to 2016. And it really found that, first, minoritized populations are underrepresented as compared to the U.S. Census. But what's very interesting is how this group kind of decreases over time. And if you look at the bottom at psychiatry faculty, the numbers are really small. If we think about, psychiatry subspecialties, females appear to be more represented, while minoritized groups continue to be on the lower end, particularly forensic and addiction. So their conclusion is that female and underrepresented populations representation within the psychiatry physician workforce is significantly lower than U.S. population demographics. And while psychiatry residency remains more diverse than any other specialty, there's poor representation of minoritized groups among psychiatry faculty and fellows, which is problematic, as we're going to see later in developing, research activities, mentorship, opening access clinically to different and diverse groups. Let's look a little bit at the background from the NIH perspective. So the National Institute of Health Revitalization Act was passed by the United States Congress and signed into law by President Clinton in 1993. It required that all federally funded clinical research prioritize the inclusion of women and minorities, and that research participant characteristics be disclosed in research documentation. This is just a summary of how the NIH has looked at minority groups. It's a readily identifiable subset of the US population that is distinguished by racial, ethnic, and/or cultural heritage. That's the Hispanic or Latino, and then, the non-Hispanic or Latino groups. And then majority group was white, a person having origins in any of the original peoples of Europe, Middle East, or North Africa. I want to make a comment about the word minority and invite you all to use minoritized instead. Using minoritized makes it clear that being minoritized is about power and equity rather than numbers, connects racial oppression to the oppression of women, and gives us an easy way to conceive of intersectionality as being a minoritized member of a minoritized group. So really important. So let's look at disparities in research. So investigators, for example, cardiovascular disease and diabetes, there are similar incongruities between disease burden and representation in biomedical research. Majority of minoritized physicians and scientists conduct research in minoritized populations with better chance of gaining the trust of communities, more cultural sensitivity. That's why it's so critical that we have more opportunities for funding and be able to grow and develop academically. Blacks and African Americans receive 13% fewer research grants than whites, and Asians receive 4% fewer. And then Pacific Islanders, Native Hawaiian, African Americans, American Indians, and Asians consistently receive lower award rates for R01s or equivalent grants than white applicants, again, that growth and academic development is a lot more challenging. Now, if we look at the participants, race and ethnicity in clinical and biomedical research helps understand how ancestral influences, environmental exposures, and social factors interact. So quite important. But most US biomedical studies fail to recruit sufficient minoritized participants, nor they focus their research factors that are most relevant to these populations. Minoritized populations lack access to specialty care centers, and it's really unrealistic to think that participants from minoritized group are going to come to tertiary health centers to be recruited for research. And it's our role as researchers and investigators to really go and look for them and invite them to be part of our work. And then there's important factors why they are not comfortable. There's fears of exploitation, financial time constraints, lack of access to information, and comprehension about research, unique cultural and linguistic differences, fears of unintended outcomes, stigmatization, and health care discrimination. Not to say that, for example, in certain populations like undocumented participants, they will be very hesitant about signing paperwork. Sometimes they get asked about social security numbers for payments, and all of that, of course, is going to make participation more challenging. Let's now look a little bit at psychocardiology, which is the area I've worked on for quite some time. So it's important to know that the burden of cardiovascular disease in Black communities is disproportionately high and is a primary cause of disparities in life expectancy between Black and white individuals. Around 30% of mortality difference between Black and white men and 40% difference in Black and white women is driven by disparities in cardiovascular disease outcomes. Social determinants of health are really key part of the development and maintenance of cardiovascular disease and risk. And I want to focus on, the social aspects of that, particularly, racial and ethnic discrimination, poor social cohesion and community engagement, as well as healthcare systems, right? Institutional racism, biases, language barriers, and lack of cultural competence. If we think about cardiovascular disease risk in Hispanic populations, chronic stress is a major problem. And there are two factors there that are important to keep in mind: racial and ethnic discrimination and adverse life events. And we know that social determinants of health, particularly discrimination and adverse life events, are important not only for cardiovascular disease development, but also for mental health. So we really need to think about including these or considering these as we execute this line of research. If we look at women, so women have specific risk factors and characteristics for the development of cardiovascular disease. And there's actually a specific profile from a race and ethnicity perspective. There's higher prevalence of hypertension in Black and Hispanic Latinx women, higher prevalence of cholesterol. But the other thing is, if we look at the Latinx populations, we cannot really clump them all together. Because, for example, Puerto Ricans and Mexican American women have higher prevalence of cardiometabolic risk factors. So we have to be really careful, even when we look at this population, how we're studying them. The other thing that it's important to think about is, what generation are they? Are they first or second generation, for example, Hispanics? Because we know that acculturation plays an important role in cardiovascular and mental health disease and risk. And those who are more acculturated, and there's some evidence about this, tend to have higher levels of risk factors. So it is really important to think about all these different areas as we study patients and we connect, psychiatric illness, psychological distress, and cardiovascular disease. So along those lines, I decided to look at some of the major trials that have been done in psychocardiology and look at sex, race, and ethnicity and see how that was conducted. When we look at the antidepressant trials, and if we look at sex, majority of participants enrolled include males. Race and ethnicity, interestingly enough, most of them don't even report it. Some report a majority of white population, but other than that, there's not a lot of data on it. Psychotherapy trial, not very different. So majority of trials include males as opposed to females, and then the race and ethnicity is majorly not reported, except for the Enriched trial that talked about a 34% of non-whites, but no more specifics. On the collaborative care, stepped care trials, for sex, majority males, although there's a little bit less difference between sex. And part of that is because these trials started a little later, 2010, as opposed to the ones I showed before in the early 2000s. So a little bit more interest in making this more balanced. However, race and ethnicity remains the same. Majority of trials have whites. Some report, percentages of African American and Blacks, but really not much there. And I want to point out that there have been trials done outside the US, or including actually a number of countries, diverse ethnic groups, diverse socioeconomic status patients. But we have to, again, be careful about generalizing that into the United States population, because again, immigration, acculturation practices play an important role in development of mental and cardiovascular health, but also our policy, our discrimination practices, our social determinants of health, all of that will impact how illness develops. So we have to be careful about that. Heart failure, in terms of sex, majority males as compared to females, and race and ethnicity, although there's majority whites, the numbers seem a little bit less further apart as compared to the original trials. And some of these trials, again, were conducted a little bit later as opposed to some of the original trials in coronary heart disease. And that led me to think about how to make a change or how to change this pattern, and decided that community-based participatory research made a lot of sense. As I said before, it is unlikely that minoritized populations will come to us in tertiary care centers. So what's the best avenue for me to go to them? So the NIMHD supports collaborative interventions that involve scientific researchers and community members to address disease and conditions disproportionately affecting health disparity populations. And as part of that, I joined the RHCP. So it's the Rochester Healthy Community Partnership. So it began in 2004 as a partnership between community organizations in Rochester, Minnesota, researchers at Mayo Clinic to address health concerns in the community. Primary aim was to improve the health of our community through community-based participatory research, education, and civic engagement. We have developed an effective community-based research infrastructure and are experienced in designing and carrying a program with community partners who also help identify health priorities with their communities. And then it's made up of dedicated partners from community-based organizations, schools, universities, medical centers, and many community volunteers. A lot of this work has centered on Latinx, Hispanic communities, and Somali communities with room to grow. So more recently, I decided to apply for a grant looking at cardiac psychological distress in Latinx Hispanic women with cardiovascular disease and risk factors, not only to examine its prevalence, but also the role of discrimination and acculturation experiences. This was through the Center for Chronic Disease Reduction and Equity Promotion across Minnesota, the C2 DREAM, which aims to research the contribution of structural and interpersonal racism to disparities in chronic disease, including cardiovascular disease and other chronic conditions like hypertension and obesity. The research center is a partnership between the University of Minnesota Program in Health Disparities Research, University of Minnesota School of Public Health, Hennepin Healthcare Research Institute, and Mayo Clinic. Funding supported by the National Institute on Minority Health and Health Disparities of the NIH. And what I wanted to do is examine cardiac distress, but I wanted to use some proxy measures as there is no measure for cardiac distress. So STOP-D, which includes anxiety, depression, stress, anger, and social support, and has been actually studied in cardiac patients. Impact of event scale for trauma, the master questionnaire for vital exhaustion, and then examine the role of discrimination, adverse childhood experiences, and acculturation experiences as part of this. So this is an ongoing project, and I'm hopeful that I can gather good information and help me with future steps in developing additional studies and intervention that will include minoritized groups, expanding what we already have in psychocardiology to these populations. Thank you.
And next we have Dr. Kelly Irwin.
Thank you so much. It's been great to learn from everybody as I've listened to the talks. We're hanging in there. We're going to get heard some stuff that can make us feel like this is hard work. And hopefully we're also starting to move towards some strategies and solutions. So we all walk out of the room feeling like there's action that we can take together. So I have no disclosures. So I just wanted to take a minute and talk about the identity that I bring into the room today. Everyone who is born holds dual citizenship in the kingdom of the well and the kingdom of the sick. Although we all prefer to use the good passport, sooner or later, each of us is obliged to identify ourselves as citizens of that other place. This is Susan Sontag. I'm a psycho-oncologist. She was talking about cancer, but I think it's equally important to talk about another aspect that she could be talking about, which is mental illness. So part of why I do this work is I live with a mental health disorder. We don't measure disability when we think about disparities in most of the research that we do, but we do know this is common. Many of us are psychiatrists. There's a reason we do this work. And so I encourage you to think about that, whatever it is that brings you into this work, whether it's your identity as a caregiver, as a patient, as a researcher, as a clinician. I think that all of us hold parts of those identity, and much like Dr. Lee shared, that's why we persist in doing this work. It's not the easiest thing or the thing that's suggested. There's some degree of personal commitment, which is critically important to harness and capture, and I think honor in doing the kind of research that can change practice. So when you Google Cancer Center and you Google mental health clinic, this is what you see. What I see when I look at this is why we need a coalition, why we think it's okay to invest so differently in two different diseases. Says everything about who we think deserves to live and die in our country. And much like was said, unfortunately, there are so many intersectional ways in which people get victimized. And I feel it's often the same people who struggle, who it may be because they have fewer access to job opportunities, to education, experience racism, discrimination due to their sexual and gender identity, due to their other components of their identity. It's often the same people. So the more that I think we can bring that understanding of intersectionality into this work, I think that will advance it. But this is what leads to the 30-year mortality gap that's experienced by people with serious mental illness, to 2 to 4 times greater cancer mortality. And it's the founding principle of which led us to create our coalition. So this is Carmen. Carmen participated in our randomized trial of person-centered collaborative care. She also is a member of our coalition who spoke at one of our virtual events. As she says, doctors can be prejudiced. Doctors need to listen more. White coats became synonymous with fear and distrust. I needed a port for my chemo. I was said this could be quick, painless, same day. Day 5, I felt like there was an elephant sitting on my chest. And I called my doctor, said, don't worry, it's gonna go away. I was crying to be seen urgently on day 8. I told them there's something wrong. I can't bear this. Please take this out, please. They said, you know what, bear it. Have some oxys, go home. And then on day 10, she went into cardiac failure and contracted sepsis and nearly died from massive pulmonary emboli. She spent many days with no return calls as she lay sick in bed, unable to breathe, in pain, without being able to think clearly. How was I supposed to make life-saving decisions? I was on the phone to follow up only to realize they forgot about me. The system is broken, and I was just a number. And she brings her identity as an LGBTQ person, as a Latina woman, as a person living with depression and a history of substance use disorder and poverty and caring for a disabled child to all of this work. So that's kind of the motivation, the why, about why we do coalition building. Because like when you're thinking about these kinds of disparities, I think we often focus first on patient level challenges. And I think it's hard, but really essential to take a step up and think about multi-level challenges. At the patient level, yes, we need to think about addressing psychiatric symptoms. We need to think about poverty-related barriers. At the clinician level, we need to realize our training system is really fragmented. We don't invest in mental health training, cross-training in oncology and mental health. that there is implicit bias and overt discrimination that occurs in our medical record and our clinical appointments. And structurally, of course, that we don't invest adequately in mental health research, in training, in care. And sometimes you can't wait and we act like it's okay. We act like we do it and we don't. And I think that one of the big barriers with research, from my perspective, is that individuals with mental illness have been systematically excluded from clinical trials. So 1/2 of randomized trials exclude people with mental health disorders and substance use. So that's 1 in 4 people in this room, just based on prevalence. And that may be the only way to potentially access a cancer clinical trial. It's a human rights violation that doesn't take a lot of money to address. So I think this is one of the intersections between DEI and research, and a role for our academic society to think about. So what can we do about it? And who's going to pay for it? Let's get real about like how you actually do this work on a day-to-day basis and make it happen, because I think it's very hard work. And I was often told not to do it, frankly, that there were easier paths to take, that we don't take care of this patient population in our hospital, which as I was sitting there listening, I was like, here I am sitting here with this exact disorder you're telling me I could never involve someone in a research trial with. How do you think that felt to me as a young investigator? And I'm only now in the adequate position of leadership in my career where I can say that to you and not worry that my whole career will be taken away from me. So it's very important to me that we listen to our community advisory board, that we pay them for their time because they are providing expertise, and that they guide our agenda for cancer and mental health equity. So we have a community advisory board who guides our randomized trials, guides our commitment to clinical innovation, and it is very challenging to constantly be advocating for funding. And this is, I come from a well-funded medical center who is very supportive of the research that we do, wants us to move things and have access to care. And yet sometimes the funding for something like this, $10,000 a year, feels like it's a huge cost. And I would argue that institutions need to step up and support community engaged research. It's not just about research funding from the NIH. We can get the funding. We got, for example, a Pew Corps Engagement Award to build the coalition, but who's sustaining that coalition? Who's going to maintain the 10 years of relationships that can do the kind of high quality randomized trials we need to do to move toward equity and not just identifying disparities? So this is our Engage Initiative or Cancer and Mental Health Collaborative. I'll invite you guys all to join that at the end. We are a global coalition with nearly 1,000 members. Our core kind of group and team here includes people with lived experience of mental illness and cancer, clinicians across disciplines. So community mental health clinicians, nurse practitioners are often underrepresented in academic medicine too, and they've been a really key partner who can we partner with. So I'll talk a little bit more about our partners. I want to talk a little bit also about how we do research differently and how it can be challenging but critically important to think about how we modify trial procedures. Oftentimes, it's really important people talk about how we need to protect populations. We do, but what about the dignity of risk? What about the fact that if people don't have access to a trial, don't have the opportunity to make a choice, they're actually losing out on a potentially beneficial intervention. So how might we do things differently? So rather than our standard like 14 to 16 page legalese consent process, if you're paranoid, if you are not a documented population, if you're just a human being, it probably isn't building understanding. So what if we change that? We have science behind this. What if instead we used a verbal consent process and we had a clinician use a process of documenting assessment of capacity to participate? We know that when we have a conversation using concrete language with someone who's trusted, we can build capacity. And that's the goal, after all, to give everyone the opportunity to understand the risks and benefits of the trial and partner in this work together and make the choice that's best for them. So we use a verbal consent process with concrete examples and repetition. How do we address this kind of structural discrimination? We need to really invest in coalitions and community partnership. And when we have choices about limited resources, we need to get real about where we're investing them. And I think from a social justice perspective, we should be investing those in the people who have the worst health outcomes. But that is often not how we make those decisions. And additionally, I think it's important to understand who are the people who care about this. And we think about like what is a principle of community organizing. I don't want to get up here and inspire someone like, oh, it's amazing work. What I want to understand is where is the cross section of what you want to achieve with what I'm doing? Where is the intersection of that so that we can both do work to move that forward together? That's really like what collective action or community organizing is about from my perspective. And so the other people who really care about this, community mental health organizations, people with lived experience of mental illness, in addition to our cancer center. So our coalition includes National Alliance on Mental Illness, our community mental health partners, the Department of Mental Health, Mass General Cancer Center, Dana-Farber. It also includes, representatives from payers, like our state Medicaid payer, and other people. Like sometimes there's just people who care about mental health, like celebrities. They've got a big following. Let's think bigger than the traditional health system if we want sustainable funding that's going to be big enough to move the needle. So I encourage all of you to think outside of the box. And how do we decrease burden for people to really meet them where they are? So to do visits in the context of their cancer care, yes, but also in their homes, communities, with the community organizations that may also care about these regions. Where is the trust? How can we think about like, okay, let's do a heat map and think about where people are accessing care and meet them there. And then similarly with technology, we know that if we do things the same way, it's going to widen disparities. So how can we take a step back and think about that differently, and ask people what technology they want to use and ask them for what? Do you want to use phone? Do you want to use FaceTime? Do you want me to text you? A lot of people text in real life, yet we're hesitant to do that in clinical care. From my perspective, it's been really efficient to use texting as a way to engage people in between appointments, and to use a steady phone to do that has been really helpful for people. So one of the strategies we took, in addition to like our initial coalition, we had support from another PCORI Engagement Award to build a community of practice to think together about how to decrease the digital divide for marginalized populations, minoritized populations, particularly focusing on people who are Latino, older adults with mental illness, and those living in congregate settings. And we created this digital toolkit, which has some good resources to think about community partnership, to think about how to create trust where it has not been earned previously, and how to kind of promote inclusion. What is a community of practice? A community of practice is a group of people who share a passion about something they do. You get better at it by doing it together. It's a pretty kind of basic idea. We care about, moving the needle on mental health discrimination. We care about decreasing the digital divide. Here's our community. And by doing this together more, we get better. So we created this community of practice to advance health equity for older adults with mental health disorders during COVID. We use principles of co-learning. So genuinely coming into this, in this case, a virtual meeting, and allowing people equal time and space to share their expertise. And really being mindful about tracking the level of partnership in that process and how fully a partner people felt. These were some of the organizations that we brought in. This picture of some of us back in the day. And these were kind of some of the themes that we generated that were critically important to think about closing the digital divide, which we could talk more about. So just to kind of think about this, I think it's a good step to think about bridges between fragmented systems, right? That's a good first step to think about how we can create bridges between community mental health clinics and the cancer center. I think I was lucky because I worked as a clinician in our schizophrenia program in our clozapine clinic and as a psychiatrist in our cancer center. I had a lot of privilege walking between both of those worlds and understood how to communicate to both of those audiences. But I think really we need more than bridges. I am very moved by this idea of like old forests. I don't know if anyone else is familiar with this idea. Maybe you've read about it. Underneath the surface of old forests, right, there are all these fungi and old roots that are connected. And if you cut down the trees and you just plant a tree, it doesn't grow the same way, right? So there is a broader network underneath us that really speaks to the strengths within us. I think that's the other challenge that I see, which is similar to what you were advocating for with the move toward equity. My experience is the more hopeless I feel about something, or the more of a marginalized identity I'm in the face with, the more I need to take a step back and think about strengths. What are the strengths this person brings into the room? So I do that with our clinical encounter, our model of person-centered care, but also with our a model of research and strategies to generate funding. What are the strengths in the community that's around you, in your cancer center? Who else cares about this? I think that it's really been meaningful and hopeful in terms of how people have stayed motivated and engaged and not burned out during COVID to come to another virtual meeting. And what people talk about is they feel that more of their identity is present in the room and how much that matters to them. So in closing, I think we need to be innovative, have multi-level approaches to build capacity, to deliver integrated care and research, and to do research at this DEI intersection, be transparent about stuff, use plain speak, build person-centered strength-based teams, be pragmatic and flexible, think about how to create communities of practice and adapt evidence-based models and use some implementation science principles and have it guided by a human rights framework. And I would invite you to join our coalition. These are some of our partners. So it's engageinitiative.org. You can take the pledge that you agree that mental illness should not be a barrier to cancer care or research. This is Carmen. I just wanted to share her closing thoughts after being part of the study. I received a call, and that call changed my life. I found someone that believed me. I didn't have to prove I was a drug addict or was made to feel my pain was imaginary. Or better yet, because of my tattoos, piercing, and the color of my skin, I wanted to exploit the system. I'm a proud, educated Latina, and my complaints had fallen on deaf ears. And she was very happy to be invited to be a partner in this coalition. So thank you very much, and hopefully you take that pledge as well.
So hello again. I am Hermia Monu, and I am charged to sort of remind you a little bit about how to pursue different questions that you may have pertaining to DEI and research. And as it has been alluded to, a lot of us here are like primarily researchers or physician scientists, but hopefully in the next few minutes, you would feel a little empowered about some of the research tools and how to pursue this. And frankly, if you still feel like this is not something that's way above you, I think a lot of research these days is all about team science. So even those of us who do this actively have to frequently collaborate with colleagues to make sure we push this work forward. So I have no disclosures. And to jump right into things, I think when we think about all studies in general, like in research methods, they can either be descriptive or analytic. And I think it's great from the plenary from our colleagues in the UK and the home study, sort of touching a little bit on some of these concepts. And starting with descriptive studies in general, the first thing I want to highlight is qualitative studies. And these are really approaches that we use to collect and analyze non-numerical data to understand different concepts, opinions, or experiences. And it's great because it can help you gather like in-depth insights into a problem or to generate new ideas. So as a physician scientist, I love doing qualitative studies, although they can be a lot of work, but they're a great way for me to partner with different stakeholders and to really bring the voices of whoever, we are trying to understand or intervene on in a really palpable way that is hard to really do otherwise. And so for each of these methods, I'll highlight a few pros and cons. So when we think about the advantages or the pros of qualitative studies, they can really help you to capture changing attitudes, capture perspectives in a way that quantitative measures don't allow you to. They can also be quite flexible and creative. A lot of people think about like interviews, but frankly, you can do like a qualitative observation by just like sitting in a room and just observing things. And it also allows you to speculate. And I think another powerful thing about qualitative studies is that it really helps you to understand like population-specific concerns. So very frequently, I have done qualitative studies where, like I had an idea for one thing, and then I walk away from the study with like a completely different idea. Like an example that comes to mind is one of the interventions that we recently launched for patients with blood cancers was to understand peer support and how that can help bridge the gap for consistent or persistent unmet needs. And I went into these interviews thinking, obviously, it's like a one-to-one peer mentor program thing. And I walked away thinking, oh, patients really want like a group experience. And that really impacted like our study development later on. And then when we think about disadvantages of qualitative studies, usually the sample sizes are quite small. And methodologically, it's not a bad thing, because when you think about things like saturation and analyzing qualitative data, you usually need about 10 to 20. But what it means is that you could also have sample bias. So every time someone signs up for a qualitative study that I do, I'm always thinking, what is it about this person that's like interested in the topic that really wants to talk about it? And then because the sample size is small, you can't also generalize the findings. So let's say in your context, you know, like how many of you here have ever been called to assess delirium? We all have. So let's say you're a new faculty in a new institution. And every time you go to evaluate a patient with delirium, you notice that patients who are Blacks or Hispanics are always in restraints. And, you know, after like the 10th consult, you start to wonder, like, what is this all about? But then you don't really know what to do about it. Like a great way to explore that qualitatively is to really interview a bunch of nurses and just understand what factors really goes into like patient A getting restraints, you know, in the context of delirium symptoms versus patient B who falls in a specific demographic. And it's an example of how, you know, something just doesn't feel right within you, and you can literally like talk to different stakeholders. You could even interview a bunch of house staff who actually put in those orders to understand how their understanding really impacts doing this specific thing for one group versus the other. The other thing I want to highlight is also cross-sectional studies. And these are great because they help you examine the relationship between different variables of interest, and it's usually at one specific point in time. The nice thing with cross-sectional studies is that the sources of data can be quite varied. So it could be from publicly available data sets, it could be from different surveys, and it could be stuff that you collect. It could be data that, you know, even very frequently we've used data from randomized controlled trials to do cross-sectional studies as well. And so when we think about these type of studies, what are the pros and cons of it? They are relatively cheap and simple and fast. So we've heard a lot about funding. And again, as a physician scientist, we think a lot about how we're going to pay for our time, how we're going to do this. But cross-sectional studies are actually a great way to like explore different questions that you have. And you don't need money to do that. You know, even when you're thinking about publicly available data sets, most of them are free. Some of them you have to pay for. And so that's something to keep in mind. They are also safe for patients because you're not asking patients to do, you're not drawing blood, you're not giving them an intervention. The data already exists. And it's also great to assess the association between different variables. So you can look at race and like length of hospital stay, or, you know, like specific disease factors like delirium and, you know, like different social demographic factors, for example. And the nice thing too is that they are usually like foundational to other studies or other things that you can also explore. The disadvantage is that a lot of the associations that you observe, you know, they don't tell you much about causation. So you can't really tell, okay, because this person is one specific race, that's why definitely this happens. And so you have to keep that in mind. And then also for a lot of survey data, you run the risk of recall bias, you know, like you're asking patients to report how they feel over a specific period of time or some specific data that may not necessarily be accurate. And then for a more statistical concept is that, you know, when you think about looking at associations between different things, you can have confounders because different factors are sort of like related to each other. And sometimes it's hard to navigate depending on your sample size and the specific analyses that you want to do. So an example of like a cross-sectional study, like in the context of like CL and like DEI that you could easily do is, you know, let's say you work in an acute psychiatric setting or like the emergency room. And over time, you're sort of curious about how come, you know, like certain groups of patients are in the hospital, in the ED for like a long period of time. So when we think about the next level of care, you are sort of curious, you know, like are older patients more likely to like board in the ED more than others? One way to like do like a simple cross-sectional study is to request, you know, like the emergency record data for like patients over a period of time. So let's say in 2023, of all the patients who were admitted to the ED that needed an inpatient level of care, by race and, you know, like different social demographic factors, how long did people stay there? Another simple thing you could also do, you could also wonder, like, we've heard about the record-breaking ACLP year. You may wonder, like, where are people coming from? So you could talk to James Vrack, and he could tell you about, you know, like who registered for ACLP this year. And you could like do like a cross-sectional association, like a lot of women coming from the Northeast, or are they coming from the South or California? The data is already there. They collected it. And so again, this is how you can explore different questions and curiosities that you have using cross-sectional methods. And then I also want to highlight electronic health record analysis, because a lot of us, for the good or bad, have to deal with the electronic health record system. And it's actually like a trove of information that's already there. There is a little bit of like skill that you need to extract the data and also clean the data before you can analyze it. But at least you should always think about that. You know, like if you use the EHR, that's something that you could use to explore different questions that you have. The other thing, the advantages of this is that it doesn't require patient recruitment. Again, a lot of us who do clinical trials, recruitment is like the bane of your existence, like trying to get people to like sign up to do your studies. For EHR data, it's already there. It's also relatively inexpensive to pursue this. And you can have a really large, diverse sample of patients that you can look at. And usually because of the sample sizes, the findings can be generalizable. Some of the cons of this is that, you know, the data quality may not always be there, because again, the people like Epic who built the EHR were not thinking about research specifically in mind. Sometimes you can have a ton of missing data based on the questions that you're interested in. And as you extract the data, you can actually also have like some error that comes in terms of, again, how the data is stored on the back end versus what you need. And an example of like an EHR data that we did recently was, so my population of study is like patients with blood cancers. And I was like sort of curious about delirium rates, because specifically in that subset of patients who get stem cell transplantation itself has advanced a lot. But I feel like whenever I'm on service, a lot of my consults are for delirium. So I was sort of curious, like, what is the prevalence of delirium like in 2022 in this population? And so we pulled the EHR data for all patients with blood cancer at MGH and the Dana-Farber. It was about 3,500 patients. And we were able to like use natural language processing and some machine learning techniques to characterize delirium in like 3,000 people. This is something that we couldn't have recruited. You know, it would have taken us years and years and years. But within a span of a year, we were able to actually like answer some of those questions that we had about that. And then you can look at like racial and different social demographic differences if that's something that you're also curious about. And then briefly to talk about some analytic approaches, you know, you have cohort studies, which can be prospective, where you're looking into the future in terms of your data collection, or you can be retrospective, sort of like looking back at like different questions that you have regarding to how the data is collected. When we think about the pros and cons of cohort studies, they are also relatively not as expensive. You can look at really large samples over a shorter period of time, and it gives you insights about possible relationships between different variables. And then there are also statistical methods that you can use to like match different participants in the study, depending on the questions that you're looking at. The disadvantage is that it's not a randomized approach to like answering different questions. Sometimes you also can't blind the participants, and you could have like a whole bunch of variables. Again, these are all statistical things that you can't really control. And then also the associations are not causal. So you have to sort of like keep that in mind. And then, you know, we've referred to a lot to like randomized controlled trials, which is sort of what a lot of us aspire to do. And the home study, which was highlighted this morning, is a randomized controlled trial. I'm not going to talk too much about it because we've heard a lot about it, but this is like the gold standard way of like determining the efficacy of like a treatment. And so again, you know, in terms of the pros, it's a highly controlled environment. This is the one way that you can determine causal relationships. It is the gold standard. And there is also like it reduces blinding bias. It's very expensive. You know, when we apply, you know, like in recent years, a lot of us who, you know, like think of applying for R01s, even with the NIH budget of like 2.5 million, it's not enough to do like, sometimes it feels like a robust randomized trial. And then it depends a lot on participant compliance, and it's long. You know, when you're doing an RCT, you're looking about like 3 years, sometimes more, to get the study done. And it's not always generalizable because everything is so perfect. So that's something to keep in mind. I also wanted to highlight case reports. and case series, which also have a lot of value, like in your day-to-day clinical experiences. As a resident, one of my mentors at the time, Ted Stern, will always tell me, every case you see that you learn something, you can share with someone else. And I was like, really? He's like, yes. And so these are also ways to like disseminate different, to share things that you're learning and disseminate things that you're learning pertaining to DEI or otherwise as well. And then also briefly to talk about QI or quality improvement. And, in some ways, QI projects allow us to like implement change right there and then in a way that sometimes it takes longer for like research methods to help you to accomplish. And then when you think about the classic PDSA cycles are like a great way to actually get this done. You can use medical records for QI projects. You can use patient surveys and comments. And then there are different administrative databases too that you can like right where you are. You could apply these principles to also answer some of the questions and things that you're curious about. And again, with the QI model, you could apply it, like right there and then. So one of the things that I did as a QI project as a CL fellow was that I realized that when we get called to see patients with limited English proficiency, it took forever to even figure out how to access the numbers for like interpreter services, who to call, Spanish, this and that, and videos. It was so confusing. So a very simple intervention that we did is I remember one time finding where the interpreter office is and then discovering that they actually have cards that you could stick to your ID badges, and literally picked up a stack of cards, brought it to the CL division, like in psychiatry. And for the past 4 years, someone has really been doing that and giving it to our residents and our fellows. And instead of like going into the directory and like looking for numbers, you can literally flip your badge and the numbers are there. It's like a very simple project that, we have to all do like QI projects as trainees. And that was something that I did. I also wanted to mention, for some of the research methods, you have to like engage the institutional review boards, which, are like a mixed blessing in some ways, but they ensure that, patients are protected and there's rigor to some of the work that we are doing. So with that, we would sort of turn it to you to think about ways in which you can apply and reflect on the conversations that we've had to answer some of the questions that you may have thinking about the intersection between DEI and research.
So we have about 10 minutes left. We want to make sure that we had enough time for Q&A. So we have two just like general prompts that we run into in your clinical experience that we can discuss as a group. Or if you guys just want to do like Q&A, like just ask and we can have a conversation. And can use the mic. Yeah, so then, okay.
I think it's on. So I think that one reason is our default language that we use that often people carry forward in clinical trials, which excludes people who can't give informed consent, including those with mental health disorders and substance use disorders. Also, as a clinical trialist, I understand that you're responsible for the adherence rates and if people complete your trials. So there's a couple of things there. One is people worry about the capacity to give informed consent. Two is people worried that people won't complete trial procedures. And so they're worried that then their trial won't have good accrual. And so I think that we've done some work to think about what support trialists would need, including like access to psychosocial oncology support. But I think that also we don't report the prevalence of people who do have mental health disorders or other disabilities in clinical trials. And that would be a really important step. So we just completed a randomized trial in patients with serious mental illness at the time of cancer diagnosis. And one of the key findings is, all right, this is possible. You know what I mean? So I think we need a precedent the other way. I can tell you the IRB gives you a lot of pushback, right, about working with marginalized populations, including people who have a guardian, for example, mailing something that might have the word mental health in it. My goodness. I mean, it's just, I work with Cancer Center IRB. They're like, what the heck are you up to? Half the time. So a lot of it's like education based. I hope that helps. Yes. Yes. So we have also done this in tobacco cessation trials for individuals and other supportive care trials. But this was a randomized trial with people with schizophrenia, bipolar disorder, and severe major depression at the time of cancer diagnosis. And the consent rate was 85%. And our dropout rate was 5. So 115 out of 120 completed the trial during the pandemic. So it's possible.
For questions, if you mind actually going to the microphone speaking, only because so then people on the recording can hear the question as well as the answer.
Slightly intimidating. Hello. Hi. So I guess a question that, because Kanari and I were just talking, we're from 2 different states where state legislature also has an involvement in how much DEI we can not do. So we were talking about how our states even differ in like what DEI initiatives we can take. So how do you navigate that when you're trying to start a project or considering different things that you want to do and you're looking for research or funding or support? Like how do we navigate those challenges and find that network or that that support from a state level, the hospital level, and even just the community? Exactly. And then, and like in Virginia, we like my residency, we just started a DEI committee and we're a little fledgling, a little committee, but we're trying to figure out what our networks are. And I'm imagining it's not going to be just potentially Texas, hopefully. And,
So I can comment on that being in Texas as well and serving on the departmental DI committee until we got disbanded. So again, depends on the state laws, but a lot of the pushback against DEI has really been focused on what they perceive to be reverse racism or reverse discrimination. Take that for the fictional term that it is. Oh, sorry, did I say that out loud? In terms of hiring practices. So from a personnel standpoint, so I'll say that like, it's still really hard for people against DEI to make the argument that we shouldn't care about patients from other backgrounds. That's still a bridge too far for at least them to say out loud. So from like a clinical and research perspective, like examining disparities and equities in healthcare, like that's still good to go in most of these states. From a like recruitment and retention perspective for staff, you get a bit more creative. And then you have to really fall back on like arguments of how this is providing like catchphrases like equal opportunity, or like helping lead to better patient outcomes. So there are ways to do it. It's just you have to think about the fine tuning of what DI means. And again, DI is not just in patient outcomes. It also refers to just like the people who we're keeping in research, who we're recruiting to research, who do the research. Anybody else?
So I want to make sure this illustrates the need for mentorship, also experience. I don't know if can you hear me? Can you hear me okay? Yeah, so, you know, it's really important that you have a guide. And research, especially in DEI research, is really, it takes skills and experience. You cannot tackle these kind of disparity research or equity research out of blue. Now, the problem also is that there aren't that many people who engage in DEI related research. It might be worthwhile to kind of think about maybe like DEI focused SIG or something like that in ACLP to really have a group of people who are interested in this area. Because if I think about, wow, I mean, if I'm a resident or if I'm a junior faculty, want to do something, and how do I go about doing it? There's state regulation, there's IRB. If you don't have a research experience, it's almost impossible to navigate by yourself.
depending on what your interests are, meeting like-minded people, you may not necessarily be able to answer the questions you want in your home state, but you can engage.
Just wanted to say thank you. Can you hear me? Am I close enough? Okay. I want to say thank you guys so much. I think all these pieces fit together really well. Something we should be talking about. So appreciate. And Shonda, we went to fellowship together.
Oh, I know.
So,
Hey,
yeah.
Jess, what's up?
Hi.
Hello, hello.
So my question is, I'm not a researcher, but I talk about research a lot, and particularly in collaborative care. I'm at UW and the AIM Center, and I just love the slide that you put up about, the gender and the race and ethnicity and collaborative care. I took a picture of that. But as you may know, one of the pillars of collaborative care is using evidence-based practice. And it doesn't sit super well with me using that term when so much of the evidence leaves out groups of people. So we've been toying around with well, when we mention that, how do we kind of accommodate for that? How are we more transparent about the studies that we're showing, like that slide? Do we put the demographics on? I don't know. So it's just, I'm not sure if you have talked about that, talking about evidence-based research and then really being more transparent about when we talk about that, who we're leaving out, when you talk with patients about that, how do you have that conversation? Just curious about any input.
Yeah, and I would also add that, a lot of us here are clinicians, in addition to what we do, to also educate yourself. So I just started my ABPN article review thing that is an option. And, as we are increasing our evidence to take a look at the results section. Again, as researchers, we sort of do that, but I think sometimes that scares people away. Even looking at statistical stuff, when I appraise in your article, I'm looking at what did they control for, and things like that. So as we are consuming the evidence to impact our clinical work, I think it's important to look at the demographics and, take what they did and, put it against the patient in front of you to inform how you are making decisions clinically. Because again, to the point, unfortunately, up until now, a lot of our evidence has not included a lot of our people.
You said you're not a researcher. So I mean, that's just something that was huge in our community of practice, huge with our community stakeholders. What does it mean to be a researcher, to really feel like you're a researcher? So I would encourage you to think about how you are a researcher. You're someone who is gathering evidence and applying it in different ways. I think that word can be intimidating in ways, but I think that we all have a way to contribute to that. And that's been really transformative for the people I collaborate with to really feel all right, I can do this research too as a social worker, as a community health worker, or whatever part of our identity. So why not? You're a researcher too.
So it begins with a question, and it actually it's a very interesting research question you're posing. Is there a racial or ethnic differences in relation to effectiveness of collaborative care? And I don't remember seeing any data, but this is collaborative care. There's been systematic reviews, meta-analysis. There's been at least 35 trials on this. So somebody's sitting on this data, probably at University of Washington, in relation to actually the size where population you could do secondary analysis to sketch out, are there actually a problem or not, right? I mean, that's what I mean by the fact that in consultation liaison psychiatry, we don't even have that problem identification disparity research. So I would love to see that kind of data being published first.
One
Otherwise, you keep guessing over and over. Like, does this work in minoritized population? We don't know.
One more practical thing we'll add is that you notice that this year was the first year we asked everyone to give a DEI statement with their submissions. And one of the things we specifically included is to talk about, is there a DEI aspect to the work you're presenting, but also where are recurring gaps from a DEI informed perspective. So to answer your question, like part of what you can do is just the simple acknowledgement that like, hey, this is not generalizable to these minoritized populations, and this is a gap we need to do better at, which can be very scary at first from like an ego perspective, like, hey, like this is something that my field hasn't done or I haven't done. But after you do it, it's actually quite liberating to be like, no, like this is a problem, right? The first step is always saying there's a problem. Go ahead.
Hi, thank you for this really amazing talk. I just had a quick question. How do you overcome the inertia after completing these types of studies or research projects to get them actually accepted and heard in the traditional research venues? I just worked on that project, The Racial Disparities of Capacity, that was published this past year. And when we shopped that manuscript around, there was a lot of sort of venues that were very reluctant to hear that.
Ooh, tell us more.
And just I mean, journals we sent and just didn't get it, or just didn't see the value in it. And I find that one of the biggest barriers for this type of research is that just the incredible or profound lack of imagination of the journals in terms of publishing this. And so that when you think about the work that people do in terms of social justice and transformative reform, they're often doing incredibly profound things, and their capacity to try to sort of break the convention and disrupt things is so inspiring. Yet when you try to do that stuff in unfortunately our fields, you're met with such resistance that it feels like entirely sort of sometimes hopeless. So how do you guys? I did. And yes, no, rejected. Psych services, though, plug for psych services. Psych services does seem to be more interested in that type of stuff. So, I do see that there's a great interest in DEI in terms of taglines, etc. But when you really present sometimes controversial ideas that really ask for disruption and transformation, you see that there's no audience for that in the traditional venues. And so
I think the
how do we
controversial
approach that?
idea is fine. It has to get through all peer reviews in relation to soundness of design and at the same time interpretation of data. Otherwise, it's a claim that's not backed up by the data. But ultimately, I'm very glad that you're able to publish a psych service. But, all data is fair in the eyes of the peer reviewers. And, but certainly these are the things that you can send it to me as an abstract first, and we can talk about, we can talk about what are the things that it needs to be before going through this kind of peer review process.
again, I would also say that, unfortunately, like our systems are not, we have a long way to go to improve our systems, but there are also certain things you can keep in mind, like as you have an idea, you Ben and people like him who are very generous with their time and have the expertise to like provide feedback. But I also think it's also helpful to like keep certain things in mind. So for example, I talked about qualitative studies. Recently I got rejected by a journal who would only accept a qualitative study with a sample size of 20. And so literally I'm in the midst of a qualitative study now. I'm appealing to the IRB. I know I'm appealing to the IRB to increase my sample size. At first I was like, we just need like 15. And so I think, there are ways to also work with our imperfect systems. And I think, we have a long way to get there. And I think mentorship, partnering with people will sort of help you overcome some of those.
I'll just add one more comment then, Vanessa. So just think like a lot of it's just culture, like getting people to come to talks like this, talk more about it, just like in everyday language. And I'm actually incredibly inspired by that idea because just think like 10 years ago, nobody's really even thinking about pronouns, right? 20 years ago, we just knew that like LGBTQ people couldn't marry, like marriage was between a man and a woman. Like 70 years ago, it was unthinkable for, like minoritized people to have like civil rights. Like 100 years ago, like women voting, like what? Like things change because we push for them to change. And then once enough people believe in it, we can actually make things change. So a lot of it's just like getting initial studies done and then just kind of building from there. Vanessa.
Good afternoon, and thank you all for your talks. I just wanted to probably offer a couple of thoughts. I don't know if I have a real question. I work in diversity, equity, and inclusion as I'm a CL psychiatrist, was a medical director for 13 years, but I also am an associate dean for now it's belonging and inclusivity because I'm in a state where you had to switch some stuff around. But my point of that is, and I've been doing social justice work since I was old enough to like drive a car, and my parents didn't have to cart me around, so it's been a while. One thought I have, and a lot of people have brought up, is why do I have to have a white paper to justify my lived experiences when you can look around in all facets and sectors of our society and see that there is evidence of systemic racism, systemic biases, injustices? You fill in the blank with your personal identification, and it's there. So it's a little bit of a pushback to like we've got to have some more disparities research, because a lot of people like, I don't need another white paper to say that people are dying because of bias. I do see the point of having evidence, so maybe a friendly amendment to that is like, yes, let's collect that evidence, but through the lens of what are we going to do about it? Like you can either have a why, like studying the why along with the evidence, or you can imagine when you're doing your hypothesis, like, I think if I do X, this might improve the situation, and maybe look at that. But to just have a paper that just has disparity actually it's not very inclusive, and it's not very equitable, and it's hurtful to a lot of people that you're trying to help.
But hopefully too, this is, like I think our ultimate goal on the meta level is that this is the beginning of these conversations. So hopefully as you walk out of the door into your institutions, you will continue to be thinking about these things, and like make new friends who are also thinking about these things here at ACLP to sort of like support you to pursue.
I'm very, very appreciative of everybody. It takes a lot of commitment. But again, the important message is it's such a rewarding area. looking back in my career, I've done different kinds of researches, maybe better funded and better, I guess, publicized. But the disparity research in Asian American community was probably the most rewarding experience I've ever had. So I do hope that people can continue that line of thoughts and interest. And please feel free to reach out to me and for any questions related to this.
Thank you all for coming.